All right, guys. A very good afternoon. Can you all hear me? Can you all see me? Audio video is clear. Right. So the objective of having this session is to understand the current trend of the exam. We'll try to analyze what are the current scenarios in which they've been asking questions. How well can we get through the exam as well? Right. Yes, guys. Okay. So our objective is to discuss as many points as possible and with a very high yielding aspect per se as well. So today I'll try to cover up the general surgery part so that you'll be able to understand much better, and we'll try to keep it a very crisp discussion. If you have any questions, you can always ask at the end of the session, or once I finish the topic, feel free to ask the questions as well. Now, one of the most important topics in the current trend of the exam is about trauma. Trauma has always been an important topic from the exam perspective, so we'll keep the trauma in the same line. Now, in the trauma, the first thing is whenever a patient is being brought to you into the casualty, you have to maintain and see whether you are required for that patient or not, because the most important resource in the hospital is you as a doctor. So we don't want to waste the resources. In order to use the resource in the best possible way, we have triage. Now, triage is a categorization. It predominantly based upon the outcome. It is not on the severity. The criteria for triage or the triage is being divided on the basis of outcome. It is not on the basis of severity. Now, the original objective of triage is in smallest possible time, how many patients can you save? That is what it takes care of the triage status, right? Now, in the triage, we have color codes. The first color code is black, which I would never want to see on my patient. That is a patient who's been brought dead, correct? Now, red is emergency. Red is emergency. Yellow is going to be urgent. Green is considered to be the orphan child of the casualty. In the green, you can leave the patient and come back again. So it is a delayed attention. It is for the delayed attention, right? This was your previous exam question, right? So triage, color coding and categorization is important. Now, in trauma, you need to understand that what is the criteria for the DCS and what is the criteria of ETC. DCS stands for damage control surgery. This stands for damage control surgery, right? A very, very important concept that you need to understand, that damage control surgery has to be a component that has to be taken into consideration, right? Any component? One second, guys. Any problem? Good afternoon, guys. Good afternoon. Okay. Are you able to hear? Can you able to see here? Any questions? Any problem in the setup? Okay. Right. So when we talk about the damage control surgery, what is the criteria that we have? Now, in the damage control surgery, the criteria is A, B, C, D, E, F, G. A stands for acidosis. In acidosis, you need to know if the pH of the body drops to less than 7.2. Now, we say the blood pressure, that is going to be systolic blood pressure if it is less than 70 millimeters of mercury. Now, we say coagulopathy is present. The coagulopathy is present. Decrease in temperature is nothing but hypothermia. Hypothermia is if the core body temperature is less than 34 degrees Celsius. Elevated serum lactate. If the serum lactate is going to be more than 5 millimoles per liter. If it is more than 5 millimoles per liter. If it is more than 5 millimoles per liter. Okay. Fresh blood, that is the blood transfusion requirement, if it is you approaching 15 units of transfusion, and if the injury severity score is more than 36, right? If these are present, then you have to go with damage control surgery. Otherwise, you can go with early total care. Now, in an early total care, we see support of inotropes is not required. The support of inotropes is not required. It is patient is normothermia. The patient is normothermia. Now, when we say the air, that means the patient is able to breathe without any problem. The blood pressure is stable. So if the blood pressure is stable, serum lactate is less than 2 millimoles per liter. It is going to be less than 2 millimoles per liter. We say excretion, that is urine output. If the urine output is more than 1 ml per kg per hour, 1 ml per 1 kg per hour, and we talk about the coagulation, it is a normal coagulation. If all these are present, you can go ahead with early total care. You can go ahead with early total care. So these are the criteria to look for the damage control surgery and the early total care that has been imposed upon a patient of trauma. Okay. Now, one of the major aspects of the trauma is about the shock, and we should be able to assess the shock based upon their presentation. So the hemorrhagic shock, which is because of excessive volume loss, can be classified into 4 different classes, right? Now, the category or the categorization of the hemorrhagic shock is purely on the basis of percentage of blood loss. Now, we say if the percentage of blood loss is less than or equal to 15, it is going to be class 1. If it is 15 to 30% of blood loss, class 2. 30 to 40% of total blood loss is class 3. Greater than 40% consists of class 4. When you talk about the heart rate, remember in class 1 the heart rate remains normal. In class 1 the heart rate, that is the pulse rate, remains the normal. In class 2 it might remain normal or increase. In class 3 it increases. Class 4 it further increases. Blood pressure remains normal in the first 2 classes, then it starts dropping and drops further. Now when you talk about the pulse pressure remains normal, then it will start to decrease and decreases significantly in class 4. Respiratory rate is normal in class 1. Respiratory rate is normal in class 1. It starts to pick up, it will pick up further, and severe tachypnea is seen in class 4. Urine output is normal in these 2, then it will be decreased, that is oliguria is noticed, and last it is anuria, complete absence. GCS is normal here. Here the patient is going to become anxious and they'll be thirsty. Here the patient is confused, and here the patient is unconscious. There is no need for blood transfusion, so here only IV fluids or oral fluids are enough. Here you would require IV fluids. If not IV fluids, you can use any other fluid. In terms of IV fluids, you can use ringer lactate. If not ringer lactate, any other like normal saline can also be used. Here we'll start the patient on IV fluids with blood transfusion. Class 4, it requires massive blood transfusion protocol. It requires a massive blood transfusion protocol. So when you say a massive blood transfusion protocol, it is defined as when more than or equal to 10 units of blood is replaced in the 24 hours period. And to avoid any coagulopathy, we will be using fresh frozen plasma. We'll be using the packed RBCs, fresh frozen plasma, and platelets in a ratio of 1:1:1. In a ratio of 1:1:1, right? So this is with respect to the hemorrhagic shock. Again, a very, very important concept that you need to remember with respect to the classification, right? Now, when you talk about the head injuries, now head injury is one of the most important trending topic, and the head injury classification of your Glasgow coma is again your previous exam question. So based upon this, how do you categorize the patient's head injury status, right? If the GCS is 15, if the GCS is 15/15 and with no loss of consciousness, if there's no loss of consciousness, it is minor head injury. If the GCS is 14/15 or if it is 15/15, if it is 14/15 or whether it is 15/15 but with loss of consciousness, it is a mild head injury. For a moderate head injury, the GCS has to be 9 to 13. The GCS has to be between 9 to 13. For severe, the GCS has to be less than or equal to 8. Now, the usual questions that are usually asked in terms of GCS is, what is the maximum GCS that is possible? The maximum GCS is 15/15. What is the minimum GCS that is possible? That is 3/15. when is there is a risk for coma? The risk for coma when there is less than or equal to 8/15. What is the indication for prophylactic intubation? For prophylactic intubation, we have to take a GCS of less than of 8/15, less than or equal to 8/15. Again, all these numbers has been your previous exam question, right? So this is with respect to the Glasgow the coma scale, which is classification of head injury. Along with that, the Glasgow severity scores. Now, we have a criteria that is called as NICE guidelines, right? So guys, so far any questions, quick feedback? So far any questions, anybody, quick feedback? Post head injury. Post head injury, right? Indication for CT head post head injury is about your NICE guidelines. So which says when would you do CT within the first 1 hour of the injury, and when will you do it after 8 hours? Now at any given point, if the GCS is less than 13, at 2 hour point if it is less than 15, if there is presence of focal neurological deficit, if there is presence of skull fracture, if there is presence of post-traumatic vomiting and post-traumatic seizures, then I will get the CT within the first 1 hour of the injury. Now, when will you get a CT? Within 8 hours. Now, in the 8 hours, the age of the patient is more than 65 years. If there is presence of coagulopathy, and if there is a retrograde amnesia of more than 30 minutes, and if it is a dangerous mechanism of injury. If it is a dangerous mechanism of injury, then CT should be taken within 8 hours, right? So within 1 hour, these are the criteria. Of these, remember, all these criteria, they point towards raised intracranial pressure, especially about the vomiting and post-traumatic seizures are the features of raised ICT. A disorder that is going to be present in the traumatic head injuries is your diffuse axonal injury. Now, this is associated with the worst prognosis. This is associated with the worst prognosis, right? Now, when you say diffuse axonal injury, right? Now, it is defined as complete. This is defined as complete disruption. It is defined as complete disruption of white matter. It is a complete disruption of white matter and gray matter. It's a complete disruption between the white matter and gray matter. When it's a complete disruption, it is a complete disruption of axons. It is a complete disruption of axons between the white matter and the gray matter, right? So when you see the white matter and the gray matter, if this is the white matter, this is the gray matter, there are axons which are present in between these two, right? So once it usually occurs in a decelerating injury where the brain is in motion, the head comes to still, and as the white matter continues to move, the gray matter is fixed, and there's a disruption between these two, resulting in diffuse axonal injury, right? So when you talk about a diffuse axonal injury, the patient will present to you with coma post injury. So post injury patient is presented to you with coma. So obviously when he is having post-traumatic coma, I would do an NCCT of the brain. Now here NCCT of the brain appears to be normal. There is no injury here. So immediately you get an MRI done. In the MRI, there is presence of punctate hemorrhage. There is presence of punctate hemorrhage between the white matter and gray matter. Between the white matter and the gray matter, that is in your diffuse axonal injury. The diffuse axonal injury is associated with the worst prognosis of all. It is associated with the worst prognosis among all, right? Now you have the Cushing Start in the brain. The Cushing Start is seen in the traumatic brain injuries. It is seen in the traumatic brain injury. Now the concept of Cushing Start is not only confined to traumatic brain injury, it is traumatic brain injury which is causing increase in intracranial pressure, and that increase in intracranial pressure is what is resulting in development of the Cushing Start. Now see, there are various ways that you can understand about the Cushing Start. I'll tell you the most easiest way to understand. Now Cushing Start is the backup or the coping mechanism of the body post injury to the head. Now, whenever there is a traumatic injury to the brain, whenever there will be traumatic brain injury, this traumatic brain injury will result in cerebral edema also because of inflammation. Now, this cerebral edema will further increase the intracranial pressure. So, let's understand what is going to happen. Now, in order to understand this, you need to know something called as the cerebral perfusion pressure. This is what we call it as a cerebral perfusion pressure, or also commonly called as CPP. It is the pressure required. It is the pressure required to perfuse the brain. How do you calculate the cerebral perfusion pressure? It is measured as the mean arterial pressure minus intracranial pressure. Now remember, the normal mean arterial pressure is going to be 90 to 110 millimeters of mercury, whereas the normal intracranial pressure is 5 to 15 millimeters of mercury. By that logic, I can say the normal CPP has to be between 75 to 105 millimeters of mercury. Right? Now, whenever there is a traumatic brain injury, what is going to happen? If I just isolate this equation, I'm saying cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. In cerebral edema, you notice that the intracranial pressure is increasing. If the intracranial pressure increases, the mean arterial, the cerebral perfusion pressure will decrease. And if see, what is cerebral perfusion pressure? It is a pressure required to perfuse the brain. When you have enough pressure, that means the brain cannot be perfused. That will result in hypoperfusion of the brain, ischemia, and death. You don't want that to happen. Body says, I am not going to leave that easily. In order to balance this, I am going to increase the mean arterial pressure, which will increase the cerebral perfusion pressure, neutralizing these two. Hence, it is going to sustain. But the question is, how is the mean arterial pressure is going to be increased? A mean arterial pressure is a component of 2/3 of your systolic blood pressure and 1/3 of your diastolic blood pressure. Now, in order to increase the mean arterial pressure, I have to increase the systolic blood pressure. How do you increase systolic blood pressure? In order to increase the systolic, what is a blood pressure? It is a pressure exerted by the volume of the blood onto the lateral walls of the vessel. Now, in order to increase the pressure, I have to increase the volume. In order to increase the volume, I have to increase the diastolic filling time. If you take this as the ventricle, the amount of blood available in the left ventricle just before the contraction is what we call it as preload, right? Now we say the cardiac output is a measure of preload minus afterload, right? It is a measure of preload minus afterload. What is preload? It is the amount of blood available in left ventricle before contraction. Afterload is the amount of blood which is left in the left ventricle after the contraction will give you cardiac output, right? Now, in order to increase the blood pressure, I have to increase the cardiac output. In order to increase the cardiac output, I have to increase the preload. How do you increase the preload? You have to increase the blood which is present in the left ventricle. Now, in order to increase the blood in the left ventricle, you have to take more time, and that is what we call it as diastolic filling time. I have to increase the diastolic filling time. It is a time taken to fill the left ventricle. Now, when the diastolic filling time increases, the cardiac output will increase because the preload will increase. Now, because of this, now when we say there is increase in the cardiac output, that increase in cardiac output will cause increase in systolic blood pressure, which will result in hypertension. Now, when the diastolic filling time increases, it is the time taken for the left ventricle to fill is going to increase. So, if the time taken for the left ventricle to fill will increase, what will happen to the rate of contraction per minute? That is going to decrease. So, you'll see there is decrease in heart rate. So, there is bradycardia. And because of raised ICT, there will be irregular respiratory rate. Now, all these put together is what we call it as Cushing Start. That is hypertension, bradycardia, and irregular respiratory rate. And the irregular respiratory rate, all these are considered to be as the component. Okay, these are the component of the Cushing Start. Guys, Cushing Start is absolutely important. Did you all get the concept, or do you want me to repeat again? A quick feedback, please. A quick feedback. Right, so we have the Glasgow outcome score. For a good recovery, a score of 5 is given. For a moderate disability, score of 4, severe disability, score of 3, persistent vegetative 2, and dead, a score of 1 is given. Dead, a score of 1 is given. Right, now remember, dead is not given as 0, it is given a score of 1, and that is an important aspect from your Glasgow outcome score. Now, in the chest injuries, we have a very beautiful concept. That is what we call it as the deadly dozens concept, right? In the deadly dozen, you have 6 immediate life-threatening and 6 potentially life-threatening injuries. You have 6 immediate, 6 potentially life-threatening. Immediate, you have the airway obstruction, tension pneumothorax, pericardial tamponade, open pneumothorax, massive pneumothorax, tracheobronchial injuries. For potentially, it is the failed chest, aortic injuries, myocardial contusion, ruptured diaphragm, esophageal injury, and the pulmonary contusion. Right now, this itself is an exam question. Do remember which all fall into immediate life threatening and which all fall into potentially life threatening injuries. Right now, one of the most commonly asked question nowadays is your diaphragmatic injuries. The most common mode of injury is going to be the penetrating injuries. It is the penetrating diaphragmatic injury is the overall most common mode of injury. Most common organ to herniate. Now remember, whenever I talk about in terms of herniation, see on the right side you have the liver which is protecting. The diaphragm is usually ruptured on the left side. On the left side, what do you have? You have the stomach. So stomach will herniate. If not, the spleen would herniate. Now large defect is associated with blunt injury. It is associated with the blunt injury. Now if I say what is in severity, severity of the injury is also more in blunt when compared to penetrating injuries. The most characteristic feature, because to identify diaphragmatic injury during the presentation is very difficult, except if you put a Ryle's tube or nasogastric tube. There's presence of nasogastric tube in thoracic cavity. Presence of nasogastric tube, as you can see here, the tip of the nasogastric tube, as it is present in the thoracic cavity, it is considered to be the most characteristic feature. Now the best investigation, see if the defect is smaller, no, even CT will not be able to pick up, it is going to be diagnostic lab. It is diagnostic laparoscopy. For management, it is to bring back the content. It is to bring back the content and repair the defect. In diaphragmatic injury. What is the lethal triad of trauma? The lethal triad of trauma is formed by number 1, metabolic acidosis. It is associated with coagulopathy and hypothermia. Right? So it is formed by metabolic acidosis, coagulopathy, and hypothermia. Right? All these three put together is what we call it as the lethal triad of trauma. Now, in order to understand metabolic acidosis, why will there be a metabolic acidosis? Because whenever there is hypoperfusion, because of volume loss, that means there is decreased oxygen delivery to the tissue. Whenever there is a decreased oxygen delivery, remember the aerobic respiration will convert into anaerobic respiration. The end product of the aerobic respiration was carbon dioxide and water. The end product of anaerobic respiration is going to be lactic. It is going to be lactic acid. Now, as the concentration of the lactic acid in the body will increase, this increase in the concentration of lactic acid will result in metabolic acidosis. Right? Now, in order to prevent metabolic acidosis, the IV fluid that will give is going to be Ringer lactate. It has got lactate which goes into liver, converts into bicarbonate, and will be able to take care of us. Now, there is coagulopathy because of excessive blood loss. So that is why whenever there is suspicion of coagulopathy, in order to prevent this, whenever you're doing a massive blood transfusion, in the massive blood transfusion, if I only give packed RBCs, it will result in coagulopathy. That is why we give packed RBCs with fresh frozen plasma and platelets to prevent coagulopathy. To prevent hypothermia, we give warm crystalloids as IV fluids. The warm crystalloids are given as IV fluids so that it can take care. Right? So this is with respect to the lethal triad of trauma. Okay, clear guys? So these are the components which you have to remember with respect to lethal triad of trauma. Now we'll be talking about the damage control surgery. Again, a very important aspect, right? So for any questions guys, quick feedback. So for any questions, quick feedback. Can we move on? Right. Now, in the damage control surgery, the stage 1 is the patient selection. We have to see which patient requires the damage control surgery. The stage number 2, it is to take the patient for primary exploration. Now, the goal of the primary exploration, it is to control hemorrhage. It is to control hemorrhage and prevent any further contamination. And to prevent any further contamination, right? Now remember, whenever we do a primary exploration, there is temporary abdominal closure. It is a temporary, will be a temporary abdominal closure, right? Now stage 3 is going to be ICU care. In the ICU care, the goal, it is to correct coagulopathy. It is to correct coagulopathy, and as you correct the coagulopathy, improve the nutrition status also. Now this is to take care for 24 to 48 hours. ICU care, the patient is kept for 24 to 48 hours. Now once the ICU care is done, then you will take it for secondary exploration. In the secondary exploration, the goal is to correct the anatomy. It is to correct the anatomy, and the final stage is your definitive abdominal. It is take the patient for definitive abdominal closure, right? So these are the stages of the damage control surgery. Now, for abdominal injuries, we have an assessment tool that is called as the FAST. For the abdominal injury, we have a component that is called as FAST. FAST stands for Focus Assessment with Sonography for Trauma. It has got a classical 4P evaluation. In 4P, I'm going to look for the perihepatic space, pericardial space, perisplenic space, and the pelvic, right? So 4 sites of 4P: perihepatic, pericardial, perisplenic, and pelvic. Now we have E-fast, that is called as an extended fast. In an extended fast, what are the sites? You're going to look for the right thorax, you're going to look for the left thorax. Abdomen is divided into 4 quadrants, that is your right upper quadrant, your left upper quadrant, your right lower quadrant, and your left lower quadrant. Altogether 6 sites are looked after in E-fast. The minimum field required for the fast to be positive in terms of collection is going to be 100 cc. It is going to be 100 cc. Now, what are the findings that you will see? Remember, presence of a seashore sign. Presence of a seashore sign indicates normal position. Now, absence of seashore sign. Absence of seashore sign, or also called as barcode sign or the atmosphere sign, is indicative of pneumothorax. Now, when we say the seashore sign, how it has been formed, you need to understand every time the pleura moves, no, the parietal pleura moves and the visual pleura moves towards the parietal pleura and then comes back. The movement of visual pleura to and fro, this movement of visual pleura as it moves, it has been detected on the ultrasound, and this motion looks like a what, seashore sign, right? Now if there is a pneumothorax, then it will compress the lung. As the lung is compressed, the pleural movement will not occur, and hence there are no sea waves. So loss of sea waves, a barcode sign is an indication of pneumothorax, right? Now whenever there is presence of tension pneumothorax, now whenever there is presence of a tension pneumothorax, in emergency, you have to perform a needle thoracentesis. In this needle thoracentesis, where will you insert the needle? If you have a child or an adult. If it's a child, then it is going to be second intercostal space in mid clavicular line. Adult, it is going to be fifth intercostal space in mid axillary line. As a definitive, we are going to put intercostal ICD. Now remember, in adult the ICD is placed of 28 French. It is of 28 French. You will see the ICD will be. This is with respect to pneumo. Right. Good evening, guys. Mansoor, it is not mandatory to do in every patient of abdominal trauma, but we say if the trauma is blunt, always get an ultrasound done. That is a fast, right? All blunt trauma abdomens should be evaluated with ultrasound. Correct. Can we move on? So of the splenic injuries, again, in trauma, one of the most important solid organ injury is going to be your splenic injury, right? Now, the most common organ to be injured, in abdominal trauma, it is going to be spleen. There is a new latest update which says liver is more commonly involved when compared to spleen, but the textbook still gives you spleen as the answer. Most common organ injury in the blunt trauma abdomen still remains as spleen. For penetrating, it is going to be liver. For mesenteric tear, for carcilt, it is going to be mesenteric. It is going to be the mesenteric tear. In the blast injuries, it is going to be bowel. The most common abdominal organ injury in blast is going to be bowel. Now, if I say what is the most common organ injury in blast injury? In blast injury, overall most common concept? Overall most common is going to be tympanic. It has to be the tympanic. Now, let's look at the grades of the splenic injury. It is done on the basis of CECT abdomen. Now, on the basis of CECT abdomen, we have grade 1. Now, in the grade 1 hematoma, it will be, now these hematomas that we're talking about, the most important, these are going to be subcapsular hematomas. These are not intraparenchymal. They don't bleed into the parenchyma. They are collected between the capsule of the spleen and the spleen per se. Now, if the hematoma is less than 10% of the total surface area, and if it is less than 1 centimeter in depth, it is grade 1, and here we will go with conservative management. Now, if the involved hematoma is between 10 to 50% of the total surface area, and the laceration is between 1 to 3 centimeters, it is still conservative management. If it is greater than 50%, and if it is greater than 3 centimeter in depth, that is in terms of laceration. Now, if the patient is stable then conservative. Then it is going to be conservative, right? If the patient is unstable, we'll try to seal the vessel from where it is bleeding. So I'll try to go with angioembolization. We'll go with angioembolization. If angioembolization fails, then we will go with surgery, and that is going to be splenography. That is your spleen preserving surgery. Splenography is your spleen preserving surgery, right? Now, when you have grade 4, in grade 4, you have intraparenchymal hemorrhage. It is your intraparenchymal hemorrhage, and more than 25% of spleen is devascularized. Is devascularized. Grade 5, it is completely disrupted spleen. It is broken down into smaller pieces. It's a completely disrupted spleen, right? Now for these two, you have to take the patient for splenectomy. And this has to be an emergency. It is called as an emergency. It has to be an emergency splenectomy. Now, one of the most important topic in the splenectomy is your post-splenectomy vaccination. And this is about emergency splenectomy. Now, if there's an emergency splenectomy, we will see the post-splenectomy vaccination, which will be divided into two categories. One which has to be done in immediate post-op, in immediate post-operative period. Another one in 2 weeks time. In 2 weeks time from splenectomy. Immediate post-op, we have to give pneumococcal vaccine. We have to give pneumococcal vaccine. Now, in 2 weeks period of time, you have to give meningococcal. We have to give meningococcal and H influenza. So meningococcal, H influenza B, and pneumococcal vaccine, right? This is your exam question, so you have to answer accordingly, right? So this is your post splenectomy vaccinations. Now, one of the most important aspects in trauma, that we want to discuss is the status of shock. Guys, so far any questions, quick feedback? Okay. Now, when we talk about shock, we have three basic shocks. Number one is your hypovolemic shock. We have the hypovolemic shock, cardiogenic shock, and septic shock. Now, the parameters that we are going to look across in order to understand these shocks. Number one is going to be the pulse rate, systolic blood pressure, cardiac output, jugular venous pressure, pulmonary capillary wedge pressure, peripheral vascular resistance, and skin temperature. So these are the parameters that we have to assess to know the status of. Right? Now, in order to understand this, I'll draw a small arcade so that you will understand better. Now, imagine if this is the central pumping unit, that has to be the heart. Heart is divided into 4 chambers. This is the right atria, this is the left atria, this is the right ventricle, this happens to be left ventricle. Now you will notice from this side onwards, you will see the aorta is going to originate. It will supply the blood to every nook and corner. Now as it supplies the blood to every nook and corner, now it is going to go into the peripheral side, where it is going to divide into 2 components. One that supplies the blood to the vital organs, one that supplies the blood to the vital organs, and another one that supplies the blood to the non-vital organs, to the non-vital organs. Now you can see more amount of blood is going into vitals, less amount of blood will go into non-vital organs. It is because of peripheral vascular resistance. A beautiful concept. It is a resistance offered by the peripheral vessels to the blood flow. In simple words, if I want to explain, let's say if this is the road that is present, right? Let's say you're driving a car and there are 2 cars which are going to go simultaneously, and there's a split road in front, and one road is like this and the other road is going to be in this particular manner, right? And then you see it is going to be, this is the route, this is the route that is going to be taken across it. Now when you say the car is going to move, let's say this is the car that is moving. Now as the car moves, in which direction can it go freely? Obviously the one which has no resistance, the flow is more, and if somebody wants to go here, very less amount of speed can be achieved here, right? So let's say if there is some fluid that is flowing, let's say there's some fluid that is flowing here. Now as it comes to junction, because there's no resistance, maximum of fluid will go here and some amount of fluid will try to go into the other side also, right? So this is what we call as peripheral vascular resistance. It is a resistance offered by the peripheral vessels to the blood flow. Now imagine if the entire blood is recollected back from the vital organs as well as the non-vital organs, and let's say we collected in one uniform compartment, and this uniform compartment is what we call it as the vascular pool. From the vascular pool, the blood is going to return back into the right side of the heart. It is going to return back to the right side of the heart, right? And the circulation continues across here. Now imagine if this is the blood, this is the blood that is coming from the vital, this is the blood that is coming from the non-vital, and the blood is getting accumulated in the vascular pool. The blood is getting accumulated in the vascular pool. This is the basic objective that is present across here, right? Now as you can see, as more and more amount of blood is here, this is the component of vascular pool that is present. I'll make it very simple for you. In order to understand this, when we say the right atrial pressure, the right atrial pressure is measured by the JVP, the left atrial pressure is measured by pulmonary capillary wedge pressure. Now on the arch of aorta, you have an extremely sensitive receptor, and this is what we call it as the baroreceptors. The baroreceptors are present on the arch of aorta as well as at the carotid bifurcation. Their job is to look for any change in pressure. Let's say when the blood is going to go from the left ventricle, as it goes into the aorta, from the aorta it will go into the vital organs, and from the vital it will go into the vascular pool, that is for the venous pool. Same for your non-vital organs, it is existent, right? Now as the blood is coming from the left ventricle, as the blood is coming from the left ventricle into the aorta, whenever catecholamines, and in these catecholamines you will see there is increase in epinephrine and norepinephrine, and the effect of epinephrine and norepinephrine on the heart, it increases the heart rate, right? Now as the blood is going to come from the aorta, as it goes into vitals, more amount of blood into vitals and less amount of blood into non-vitals because of peripheral vascular resistance, right? Now let's say this is segment A, heart, let's say this is segment B, and peripheral vascular resistance segment C. Wherever there is damage in segment A, it is hypovolemic shock, segment B is your cardiogenic shock, and segment C, it is going to be your septic shock. Okay, as simple as that. Let's try to work out and see how we are going to understand better. We'll talk about the hypovolemic shock, where there is a damage in segment 1. Let's say there is some injury that has occurred in the vascular pool. Now, because there is an injury in the vascular pool, because there is injury in the vascular pool, you will notice the blood will start to leak out from here. Now, as the blood will leak out, the volume of blood available in the vascular pool is going to decrease, right? Now, if the volume of blood in the vascular pool is less, that means the blood which is coming from the vascular pool, the blood that is coming from the vascular pool into the right atria will be lesser. So the volume of blood coming in the right atria will decrease. If the volume of blood in the right atria will decrease, the right atrial pressure will decrease, and the right atrial pressure is measured by JVP. So JVP in the hypovolemic shock will decrease. If the blood in the right atria is less, the blood in the right ventricle will also be less. That means the blood coming back to the left atria will be less. So the pressure in left atria will also be less, resulting in decrease in pulmonary capillary wedge pressure, right? Now, if the blood in the left atria is less, that means the blood in the left ventricle is also less. So the amount of blood available in left ventricle is what we call it as preload. This is what we call it as preload. I just told you that amount of blood which is left after contraction is called as afterload. And in order to understand the cardiac output, you have to minus preload minus afterload. Now, if the blood in the left ventricle decreases, that means preload decreases. By simple logic of equation, I would say the cardiac output will decrease. Right? It will decrease in cardiac output. Now, if the cardiac output decreases, that means the amount of blood coming from the left ventricle to the aorta will decrease. So the aortic pressure will drop, and aortic pressure is measured by systolic blood pressure. Systolic blood pressure will drop. Now, as the systolic blood pressure drops, as the pressure in the aorta decreases, I told you the baroreceptors are going to get activated, catecholamines, and increase in heart rate. So you will see there will be increase in the heart rate in hypovolemic shock. Now, as the blood going to the periphery is less, you require more amount of blood to be present in vital organs. So, in order to push whatever amount of blood is available, the peripheral vascular resistance, that is resistance offered by your peripheral vessels, will further increase so that more amount of blood can go into the vital organs when compared to non-vital organs. Skin is an example of non-vital organs. So, blood supply to the skin will decrease, and the blood is responsible for calorigenesis. When there is no blood, there is no heat, and the skin temperature will fall. That is why in shock you have cold peripheries. Yeah, this is how you will understand the status of shock. Clear, guys? So far, any questions? Okay. So, in cardiogenic shock, you say the heart is not able to contract effectively, right? Best example for this I can give you is a cardiac tamponade, where the heart is covered by or restricted by the collection of blood around it, and this is going to result in cardiogenic shock, where the heart is getting restricted. So heart is not able to contract effectively, resulting in cardiogenic shock. Now, if the heart is not able to contract effectively, that means the blood coming from the heart to the aorta will decrease, right? So that is going to be your cardiac output. So in cardiogenic shock, you will see the cardiac output will decrease. If the cardiac output decreases, the blood coming back from the heart to the aorta will decrease, so aortic pressure will drop. If aortic pressure drops, baroreceptors get activated. Activation of baroreceptors cause increase in catecholamines, epinephrine, norepinephrine, which will cause increase in heart rate. Now, as the blood in the aorta is less, blood going to the periphery will also be less. In order to compensate, the peripheral vascular resistance will increase, so that more amount of blood can go to vitals, less amount to non-vitals, hence skin temperature will decrease. Now, what is going to happen as the blood in the circulation is less, blood coming back to the vascular pool will be less, blood going back to the right atria will be less. But the problem is the right atria already has a lot of blood, because heart is not able to contract to eject out. All four chambers are filled with blood, and it will cause increase in pressure. So you will notice the JVP and the pulmonary capillary wedge pressure will be elevated, and this is how you work out your cardiogenic shock. Now, in septic shock, what will happen? In septic shock, there is loss of peripheral vascular resistance. Now, you need to understand the concept of septic shock in two words. Number one, there is loss of peripheral vascular resistance. And number two, there is universal. There is universal vasodilation. That means the entire blood vessels, right? Every blood vessel in the body is dilated. In septic shock, we say the peripheral vascular resistance is lost. if the peripheral vascular resistance is lost, that means the blood to the vitals and non-vitals will now get equally distributed because there's no resistance, no, there's nobody to stop it. So skin will start getting more amount of blood than required. So obviously when the blood increases, the heat production increases. When the heat production increases, the calorigenesis increases, so skin temperature will increase. And that is why your septic shock is also called as warm shock. Also called as warm shock. Now, if the blood in the septic shock, what is happening? The blood is getting distributed among vitals and non-vitals. It's not going anywhere outside. Now, as it is distributed to vitals and non-vitals, obviously it is going to recollect back. Now, as it recollects back to the vascular pool, the blood in the vascular pool remains constant. That means the blood going back to the right atria. The blood going back to the right atria will also remain constant. Because of this, the JVP and the pulmonary capillary wedge pressure initially remains normal, right? Now what is going to happen? The blood from the left ventricle is going to come into the aorta. Now because the volume of blood in left ventricle is same, so I can say the cardiac output. Now here is a very important concept, right? What is the difference between a Stoke volume? Difference between the Stoke volume and cardiac output. Now very simple logic. Stoke volume, it is the volume of blood. It is the volume of blood ejecting from left ventricle with one contraction, with every contraction. That means how much amount of blood is ejecting with every time the heart contracts. That is the Stoke volume. What is cardiac output? It is the Stoke volume, that is ejection per minute. So this is per contraction. So volume per contraction, cardiac output is measured. It is the volume of blood. It is the volume of blood ejecting from left ventricle every minute. So in 1 minute, your cardiac output per contraction, it is Stoke volume. Why I'm telling you this is because when we say cardiac output, the cardiac output is a measure of preload minus afterload, right? It is preload minus afterload. Another way you can measure the cardiac output. Cardiac output is also equal to Stoke volume into heart rate. Either ways you can measure, right? Now, the problem here is the amount of blood in the left ventricle is normal, so preload is normal. If the preload is normal, we think the cardiac output should also be normal. But here is the catch. What is going to happen? I told you there's universal vasodilation. The aorta also dilates. So the Stoke volume is normal. That means the blood coming back or from the left ventricle to the aorta is normal, but the aortic size increases. Volume of blood coming to the aorta is normal, but the aortic size increases. What will happen? Net pressure. The net pressure in the aorta will drop, causing decrease in systolic blood pressure. Parasympathetic activation, catecholamines, it will cause increase in pulse rate. What will happen to the cardiac output? Cardiac output is equal to Stoke volume into heart rate. Now it is the amount of blood ejected per contraction. It is same as before, and you say the heart rate has increased. Because of it, the cardiac output will increase. So you will notice here the cardiac output initially in a compensated phase of septic shock increases. Yeah. So this is how you'll work out the parameters of shock. Is that clear, guys? Quick feedback. Yeah. Clear, guys? Can we move on? If you have any questions until now, this is the bare minimum in trauma as well as general that you need to know. Okay, chal. So we'll talk about the other small topics that are important for the exam. We're talking about a very, very important topic. Nowadays, it has been a very uptrend that is present, and that is nothing but your nutrition, right? Now, in the nutrition, one of the most important is the indication of TPN. TPN stands for total parenteral nutrition. TPN stands for total parenteral nutrition, right? Now, what is the indication of total parenteral nutrition? The number one is short bowel syndrome. The first one is short bowel syndrome. The criteria is if the length of the small intestine is less than 200 centimeters, that is your short bowel syndrome. Next is your high output enterocutaneous fistula. In a high output enterocutaneous fistula, if it is more than 500 ml of output in 24 hours period. If there's a presence of acute active inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus. But remember, the most important indication is unavailable. It is an unavailable enteric route. If there is unavailable enteric route, then we would go ahead with total parenteral nutrition, right? Now, in the TPN, one of the most important aspects is the composition of TPN. Remember, in the composition of TPN, the most important is carbohydrates. The amount of carbohydrates that are going to be present is around 40 to 50% of your total volume of TPN, and this is going to give you a 3.5 kilocalories per gram. Fat consists of 30 to 40% of the total volume, and this gives rise to 9 kilocalories per gram. Proteins consist of 10 to 20% of total volume, and this gives rise to 4 kilocalories per gram. This gives you 4 kilocalories per gram, whereas vitamins and minerals are trace. Well, I'd say they are minimal. So the presence of vitamin and trace elements which cannot be quantified, but these are present. Now this is your very important exam question. It is these numbers, right? They have given you that there are 80 grams of carbohydrate, 50 grams of fat, and 60 grams of protein. What is the total energy that is released? And that can be calculated by this simple concept, right? Now what is the complication of TPN? Now you have the tube related complication and the feeding related. Rather than tube related, we say it is line related. We call this as the line related complication, not tube related. It is the line related complication, right? Now in the line related complication, number one, line sepsis. It is the line sepsis is the most common line related complication. It is the most common line related complication. But apart from line sepsis, there is line dislodgement. There is line dislodgement. During insertion of line, there could be presence of pneumothorax. There could be presence of pneumothorax. There could be your cardiac tamponade. Can be associated with cardiac tamponade and can development or develop air embolism. Along with air embolism, it can also be associated with thoracic duct injury. It is also associated with thoracic duct injury, right? When I say feeding related, one of the most important is going to be your very important concept that is called as refeeding syndrome. It is called as the refeeding syndrome. Now, in the refeeding syndrome, the concept is very simple. Before the TPN was started, patient was starving. Now, because patient was starving, there was less amount of sugar in the body. So, in response to that, there's less amount of insulin that is present. So, when you start the patient on TPN, as you know, 40 to 50% is carbohydrate. So, there is sudden surge of sugar that is present. Now, to compensate this sudden surge of sugar, there will be excessive insulin that is going to be produced. Now, this insulin is going to activate the sodium potassium ATPase pump. It's going to activate the sodium potassium ATPase pump. Now, because of this activation, what is going to happen? The sodium is also going to go in, but the potassium that is present, the potassium which is present outside the cell will now be flushed into the cell, and that will result in hypokalemia. But along with that, it is associated with hypophosphatemia. It is associated with hypophosphatemia, hypomagnesemia, hypokalemia, hypomagnesemia, and associated with thiamine deficiency. It is associated with thiamine deficiency. Right? Uh, another important electrolyte imbalance. Another important electrolyte imbalance that you will be asked is your CHPS, that is congenital hypertrophic pyloric stenosis. In CHPS, what do you find? What are the electrolyte imbalance? There will be hypochloremia. There will be hypochloremia. There will be hypokalemia. There will be hypokalemia with metabolic acid alkalosis, and paradoxical aciduria. Paradoxical acid, right? So these are feeding related complications and the electrolyte imbalance in CHPS. Okay, guys. So this is with respect to total parental nutrition. Right? Another important aspect is about the cleft lip and the cleft repair, or the cleft palate repair period. Right? Now, when you have a patient who's having a unilateral cleft lip, single surgery repair should be done in the month of 5 to 6 months of age. When there's a bilateral cleft lip, again single surgery, but this time it should be done between 4 to 5 months of age. When there is a cleft soft palate, in single surgery at the month of in the 6th month. When there is a hard palate, single surgery between 15 to 18 months of age. Between 15 to 18 months of age, right? When you have a combination, now you have a combination of both cleft palate, which is soft and hard, so you have to do 2 surgeries. For your soft palate, it has to be done on the 6th month. For the hard palate, between 15 to 18 months. When there is a cleft lip in the palate, which is unilateral, again 2 surgeries has to be done. The first surgery is going to be a cleft lip has to be done along with soft palate at the 6th month of age, right? And then you can do a hard palate repair between 15 to 18 months. When there is a bilateral, again 2 surgeries. This time you have to do a cleft lip plus soft. Because it is bilateral, I'll start at 4. This is 5 to 6 months. This is 4 to 5 months. And the second surgery is of the hard palate between 15 to 18 months. Right. So the age of repair is going to be very, very important in cleft lip and palate. So this is with respect to cleft lip and cleft palate. Okay. So now, another important topic that has been asked in your exam is what is the causes for graft failure, that is a split skin grafting. We're talking about in terms of split skin grafting. The split skin grafting is also called as the partial thickness skin grafting. It is also called as the partial thickness skin grafting. A partial thickness skin grafting. Remember, the most common cause for graft failure is development of hematoma followed by seroma. Now, we know that post grafting, there could be development of seroma. Seroma and the hematoma can be collected between the graft and the recipient bed, right? So there could be development of hematoma and seroma, right? So I'll say, let's say this is the hematoma. This is the hematoma, and this happens to be seroma. Now, I don't want the hematoma and seroma to get collected here. So in order to prevent the collection, we do a technique, and this technique is called as pie crusting, putting multiple stab incisions on the skin graft, so that this seroma and hematoma which is present here can escape out, right? It can escape out and does not allow it to settle down, right? Another reason why there could be a graft failure is because of repeated movement of graft site. It can also be because of infection. That is why preoperative graft cultures are very, very important. Remember, presence of beta hemolytic streptococci. that is a beta hemolytic streptococci, is an absolute contraindication. It is an absolute contraindication for skin grafting, and if there is absence of periosteum in the bone, will also result in graft failure. It will also result in graft failure, right? So these are the causes for graft failure overall. Yeah. Now, what is the difference between a partial thickness skin grafting and a full thickness skin grafting? A partial thickness skin graft is called as a Thierch graft or a split thickness graft. This is called as Wolfie's graft. Now, remember, in partial thickness, we are going to take epidermis and a part of dermis. Full thickness, you have epidermis and dermis complete together. So, partial thickness may we'll be taking epidermis. We'll take an epidermis along with part of dermis. Whereas in full thickness, we will take epidermis also, but along with epidermis, the entire dermis of the skin is taken. The entire dermis of the skin is taken, right? So device used is either a Humbee's knife or an electric dermatome. How do you know that you've taken the correct thickness? In a partial thickness skin graft, there should be presence of punctate hemorrhage at the donor site, and if there is subcutaneous fat is exposed, it is a full thickness graft, right? Now, donor site defect in your split thickness graft, it is temporary, whereas this is permanent. There is no scar here, it will leave a scar. You can take any size of the graft in split thickness. Here we recommend only small. Repeat grafting can be done, this cannot be done here. The most common site is going to be lateral aspect of the thigh. It is the lateral aspect of thigh. Here it is retroauricular, that is behind the ears. Here it is retroauricular, that is behind the graft survival is good because it requires less nutrient, whereas it is poor. Now here you will notice that there is more of secondary contracture when compared to primary. Here primary contracture is more when compared to secondary. Cosmetic outcome is poor here. The cosmetic outcome is good here. What is the primary contracture and secondary contracture? The primary contracture is as soon as you take the graft from the donor site, as it contracted is primary. After putting onto the recipient site, if the graft contracts, it is secondary. Primary is predictable, secondary is not predictable. That is why after you put and it starts crumpling, it starts contracting, it gives you a very poor cosmetic look. Hence, it is going to be in that context. Okay, so that is with respect to split skin grafting and the full thickness skin grafting. Yeah, guys. So we'll take up general topics again. So today we'll try to finish the entire general topics that we have, and then we move across. We'll be talking about the image-based journal questions that we have. That is going to be drained. So far, any questions, guys? Quick feedback. Okay. Now the first one that you can see, it's an image of a drain. This is because it is orange in color, it is latex, or also called as rubber. It is latex or rubber corrugated drain, right? This is basically an open drain. This is an example of an open drain, right? When you see here, it is white in color. It is silicon corrugated drain. This is your silicon corrugated drain. This is also an example of an open drain. This, we know, it is your Foley's catheter. This is your Foley's catheter. It's a self-retaining catheter. It has got a self-retaining catheter. Now you can see this is here from the air is inflated for balloon. Air is produced for inflating the balloon. Now, sorry, we use distilled water. So we use any fluid for inflating the balloon. because if you put air, it will rise up. You don't want air, it has to be fluid. Usually you can put distilled water. This is where you have the balloon that is going to inflate, and from here you are going to collect urine. It is for urine. This is for urine collection. This is what we call it as the three-way Foley's catheter. This is what we call it as a three-way Foley's catheter. It is used for bladder irrigation. This is used for bladder irrigation. Now, when you see across here, this is to inflate air. So this is to inflate. It is an inflate balloon by fluid. Now, whichever is the biggest one, this is for urine collection. This is for urine collection, and one that is present at the bottom, it is to irrigate. This is to irrigate. Yeah. Now, when you see this one, this is what we call it as the Penrose drain. This is what we call it as the Penrose drain. This is what we call it as the Romovac suction drain. It is a closed drain. This is an example of closed drain that works on the negative pressure. This is what we call it as T-tube, mostly used for CBD exploration. Mostly it is used for the common bile duct exploration. This is what we call it as the pigtail catheter. This is what we call it as the pigtail catheter. This is your nasogastric tube, also called as the Ryle's tube. Remember, the average length is going to be 100 centimeters. To measure the adequate length, to measure adequate length, to measure the adequate length, we use a rule that is called as the next rule. In the next rule, we'll take the Ryle's tube, put at the tip of the nose, from there to earlobe, that is nose, earlobe, zippy sternum. Nose, earlobe, zippy sternum, we're going to put to measure the length of the nasogastric tube, right? This is what we call it as the Jackson-Pratt drain. This is what we call it as Jackson-Pratt drain. Now, this is what we call it as the Sangaskin. This is the Sangaskin Blakemore tube. The Sangaskin Blakemore tube is used for bleeding esophageal varices. It is used for bleeding esophageal varices. That is your Sangaskin Blakemore tube. That is your SBT tube, or also called as the Sangaskin Blakemore tube. Now, another important image-based questions are your cannulas, the color code, flow rate, and the size. Now, orange color cannula is going to be a 14 gauge with a flow rate of 240 ml per minute. With a flow rate of 240 ml per minute. Gray is going to be 16 gauge at a flow rate of 180 ml per minute. Then your green cannula, which is 18 gauge with a flow rate of 90 ml per minute. Then you have pink cannula, which is going to be 20 gauge, a flow rate of 60 to 65 ml per minute. Then you have the blue cannula, which is a 22 gauge with a flow rate of 30 to 35 ml per minute. Yellow is going to be 24 gauge, which is going to be 20 ml per minute. Last one is violet or purple, which is 26 gauge at 12 ml per minute. At 12 ml per minute. So this is your cannulas along with the color codes, right? Now, how do you remember them? right? Because the sort of colors, you have all the codings. Now, how do you remember it or recall? It's easy way. Now, remember the core of the earth is made up of lava. Lava is going to be orange in color, right? Then you have soil. The soil is made up of gray, so this is going to be gray soil. On top of this, you have this green trees which are going to be present. On top of these green trees, you have this pink flowers that are present. Now, on top of the pink flower, you have the blue sky. You have the blue sky that is present. So this is the blue sky that is present across here. Now, in the blue sky, you have the yellow sun that is present. From there, you have the purple universe. This is the universe which is darker in color. If you don't believe it to be universe, I will put some stars for you so that you can imagine. When you look across here, 14 gauge, 16 gauge, 18 gauge, 20 gauge, 22 gauge, 24 gauge, 20. Okay. So this is how you'll remember the cannulas, their color code, and the flow rate. The flow rate. Okay. So again, these numbers and this particular status is very, very important. Okay, guys. Now, laparoscopic instruments are again the recent trend that has been asked in your exam. So a lot of questions has been asked. In laparoscopy, the first image that you're able to see right now, these are the images of number one. This is what we call it as the port, and this is what we call it as the trocar. The difference between a port and a trocar, the port is hollow, the trocar is solid. Now, if it is bigger in size, it is 10 millimeters. If it is smaller in size, it is 5 millimeters, right? The port exists in two forms. Standard size, we have the 5 millimeter port and a 5 millimeter trocar. And a 5 millimeter trocar that you have. Now, this is what we call it as the lens, which is attached to the camera. The most commonly used lens is a 30-degree lens, which will have a wide viewing angle. There is a wide viewing angle that is present, right? When you see the trocar, when you have a blunt trocar, this is an example of a blunt trocar, which is an atraumatic trocar, which is an atraumatic trocar, and this atraumatic trocar is what we call it as the Hansen's port. This is what we call it as the Hansen's port. Then you see there is this one. This is called as SILS. SILS stands for single incision. There is single incision laparoscopic port surgery. SILS stands for single incision. It stands for single incision laparoscopic port surgery. You see this needle, this is what we call it as the Veress. Now, Veress needle, it is used to create pneumoperitoneum. It is used to create pneumoperitoneum. It is used to create pneumoperitoneum, right? Now, couple of important questions on the Veress needle. The angle between the Veress needle and the body, right? The angle between the Veress needle and the body is going to be 45 degrees. But if I ask you the angle between the Veress needle and the skin, it is going to be 90 degrees, right? Veress needle is going to be pointed towards the pelvis. It will be pointed towards the pelvis. The most common gas used for creating pneumoperitoneum is carbon dioxide. The initial flow rate is going to be 1 to 4 liters per minute. The maximum flow rate will be 20 liters per minute. The intra-abdominal pressure should be between 12 to 15 millimeters of mercury. Accidental port placement injury, keep the port in situ. keep the port in C2, don't draw it back, and perform exploratory laparotomy. Perform exploratory laparotomy over the port guidance. The port will guide where exactly the injury has occurred. That is for accidental injury while placing the port. Yep. Now, there are certain angles that you need to understand. Just to be clear, I'll just put it across here. This is where you have the lens. So this is called as the optical port. This is called as the optical port. This is what we call it as the working port. This is the working port. This is one working port. This is also another working. Now remember, angle between the port and the body. This is angle number 3. This is what we call it as the elevating angle. This is what we call it as elevating angle. The angle between the two working ports. That is angle number 1. This is what we call it as the manipulating angle. This is what we call it as the manipulating angle. The angle between the optical port and the working port. This is what we call it as the azimuth angle. This is what we call it as the azimuth, right? So these are the angles that you should be knowing with respect to the port placement. Yeah. Now, energy devices are again a very important topic from the exam perspective. We have the monopolar, we have the bipolar, the harmonic, and the thunderbolt, right? The monopolar and the bipolar are the devices which are going to be using two components. We use them to cut and coagulate. Now, when I talk about the cut and the coagulate, it's the cut current and the coagulating current. How do you differentiate that? Now, we have two things that you need to understand in the current status. Whenever the current is going to flow, we have to see the amplitude and the frequency, right? So we have to see how much is the amplitude and how much is the frequency. Now, in the cut current, you will see there will be low amplitude but high frequency. This is your cut current. In the coagulating current, we call it as the voltage or the frequency. Voltage and the frequency. In the coagulating, you will see there is high voltage but low frequency. This is your coagulating current. So this is your cut. So cut is going to be low voltage but high frequency. Coagulating current will be your high voltage but low frequency. Low frequency. Right. So this is here. This is this graph. Right. So this is your cut and coagulating current. Right. This is what we call as harmonic scalpel. Remember, harmonic scalpel can vibrate at a frequency of 20,000 to 50,000. It can vibrate at a frequency of 20,000 to 50,000 hertz. Right. Now this uses heat energy. It creates heat and does a protein denaturation. That is, this frequency will create friction will generate heat, and that heat will result in development of protein denaturation. Thunderbolt is a combined energy source. This is what we call it as a combined energy source. Now, in a combined energy source, it will be combining the electrical energy as well as the ultrasound energy or the ultrasound frequency. It will use both the electrical as well as the ultrasound vibration. Okay. Yep. So this is all the energy devices, the monopolar, the bipolar, the harmonic and the thunderbeat. मुस्कान yes, ये MBBS की क्लास ही चल रही है. This is a surgery lecture. Okay. So this is about the energy devices that you need to, right? So this is the bare minimum and the basis of the general surgery that you need to know. We have covered the trauma in general. We have covered all the devices which are present. We have covered all the drains. We're talking about the important aspects that you need to know with respect to your general surgery topics as well. So if you have any questions, feel free to ask, guys. This is going to be this end session today, and we'll continue tomorrow with the rest of the systemic part as well. So far, any questions, guys? Quick feedback. Final year mein you'll have the surgery, no? If you have any questions, feel free to ask. Quick feedback, guys. Andy, I teach only surgery. I'm surgeon by profession, so I can only teach surgery, and that's what I do. Okay, so if you have any questions, feel free to ask. Otherwise, thank you, guys. We'll resume back tomorrow morning. Tomorrow evening at same time at 5 o'clock. The session will be for 2 hours. That is around 5 to 7, and we'll start to wrap it up all the topics in systemic surgery as well. Right, chalo. So that's it for today, guys. Thank you. Thank you. Bye. All right. Okay. Thank you, guys. Mansoor, can you repeat your question, please? Andy, FMG mein, these are the topics which are now being at trend. So I'm trying to cover all your last 5 years topics as sessions. So we'll try to cover up as many repeat topics have been asked with very high yield importance. Okay. So this session should give you at least, majority of the topics should be covered for your exam. I'm not going to say it is going to be, the same questions will come and all that. But yeah, the topics would help you a lot because these are also very conceptual to revise in the same concept. Mansoor, your question for cleft lip, I guess, it is caused by incomplete fusion of the nasomedial or the intermaxillary processes, right, on the second month of the embryonic development. Right. So that's it for today, guys. Signing off. Right. See you tomorrow on the same time. Thank you.